patient number 8. Here we have an 83-year-old male, Caucasian, with a family history negative for GI neoplasms. He's a former smoker, not a drinker. Previously underwent aortic aneurysmectomy, PTCA with stenting, and in January of this year had a tonsillary hypertrophy that was biopsied and showed mantle cell lymphoma. In April, he was admitted to the hospital for dyspnea, and blood tests revealed a hemoglobin level of 6.4 grams per deciliter, which was treated with a blood transfusion. He also underwent EGD and biopsy, which showed a submucosal ulcerated protruding lesion of the gastric body with bleeding. The bleeding was treated with a hemospray, and the histological report showed antral mucosa with foveolar hyperplasia and fibrin.
Maybe we should start with the endoscopic view. Oh yes, we see, I don't know if you have the endoscopic view. There is a lot of fluid in the stomach.
Yes, but it's not so informative.
I fully agree, but I'm struggling to get it. Can I get some water or something to clean the lens here?
We can't hear your suction.
Yeah, I'm very sorry for this, but it's a little bit short.
It's coming, it's coming. There we go.
Yeah,
okay,
yeah.
good, good. Push in a little more and...
Yeah, there is bile and
a pill.
Yeah, and something on my... Yes, thank you, thank you.
What is that?
Okay. That's better now.
Okay, there.
Okay, there we go. So you understand why there was some bleeding when the biopsies were taken from the top of this lesion. The lesion is, yes, about 2 centimeters. It's a little bit pedunculated, so the attachment is about 1 centimeter wide, and you see the angulation. So this is not typical of a GIST, because usually GIST are really starting from the muscle propria, and they have the angle is how do you call that in English?
Yeah, it's it's more not like this.
Yes,
it's more like this. Yes,
it's up to it. Yes, and this is.
But some can be exophytic on the back wall and the inside wall.
And you understand the bleeding that was caused on the. It's completely ulcerated. And I think the bleeding was stopped with a clip and then hemospray by the Cook company. So for me, this is not a typical GIST, but it's indeed a submucosal lesion because you see normal mucosa on top of the tumor, and it's ulcerated at the apex. So we move now to the EUS image, and we will try to see the connection of this lesion with the
So what? Silly question. What's the point of doing an EUS in this case?
A lot of water in the stomach, do you think?
Yeah, I will have to put some water in it, but when I went down with the scope, I was immediately on the lesion. So you see the lesion here. Okay. Yes, what's the point to do EUS? I think it's a good question. This is a lesion about 2 centimeters. I think maybe a little bit more. We'll have more precise measures. Do you have the EUS image here? Yeah, maybe you can show the lesion. Can I get some water here just to? But I think we have a good view. We don't need a lot of water because this is a sedated patient without any intubation. We see it's a hypoechoic lesion with some vascular or hypoechoic spaces. Just put some water, but not much. Yeah. And one more syringe. Okay. Yeah, sorry, we had no preparation here, so it's real live. Okay. Okay, and here we can more precisely see the connection between.
The muscular fourth layer is probably...
Yeah. Try to stabilize myself a little bit. Okay. Here.
So you can see the normal wall here.
Yes.
Splitting.
Maybe show the layers. So
Yeah, so here's the serosa, the white serosa, muscularis, dark here. Whoops.
sorry. Yeah.
And then submucosa, which is hyperechoic. Then the mucosa. And in the muscularis, you can see a little white line, which is probably the
Incision.
band in between the
depth,
inner
less
circular
depth. Yes.
outer longitudinal.
Yes. One more. Yes. Okay.
So genuinely, you want to try and find, I think, the transition zone to see what layer it's coming out of. But again, to me, what's the point here? Because to me, this is a symptomatic lesion. It has to come out. So for you, the EUS can change what?
Well, I think if the EUS shows that it's submucosal rather than arising from the muscular propria, it may be a good indication for I would say, safe endoscopic resection.
Right. Okay.
If we say if we see it arises from the muscle, like we see here, I think. Can you freeze this maybe? Yes. We see the pointer. We see that the lesion really arises, I think, from this picture, but we will make more pictures to be completely sure of that. We see the submucosa here and the lesion that's connected to the muscular propria. And we don't see any layers under the lesion. So it seems to be indeed lesion arising
layer, yeah.
yes, from the fourth layer. So that means that we will have a talk. There is a mini symposium on GIST tomorrow, and we'll try to explain you what you can safely do and what's maybe not so safe by endoscopic resection. But indeed, if it's arising from muscular propria, I think it's surgical resection. Yes, we can defreeze it.
And do you think there's any need to do FNA or true cut or something?
Well, this lesion is symptomatic, so it should be treated either by endoscopic or surgical resection. FNA is mainly indicated in large lesions for patients that would undergo
in an elderly patient, perhaps if it was near the pylorus or
sorry.
in a more difficult surgical position, you might FNA it, but not here.
So, Pierre,
yeah, I think it's not a good indication for FNA, I think, this case. And especially there was a bleed already yesterday. The role of EUS is also to differentiate from other
lipoma or something.
Lipoma.
Yeah.
This is not looking like lipoma. There may be some interest in using contrast because GISTs are usually taking up contrast, and some of you quite diffusely in the tumor, which is completely different from lipoma or leiomyoma. Maybe we can use fine flow already to check.
To see if there's vessels, yeah.
If there are vessels.
You can see there's there's quite a lot of, it looks like there's small vessels.
But some of you may be of interest to increase the, to more precisely analyze the vascularization and do the differential diagnosis with leiomyoma. You clearly see again on this picture, maybe without, the connection
Yeah, that's
with
a
the
nice
muscle.
picture.
Yes,
Yeah,
very
right
nice.
here. Yeah. Our surgeons, even if it's clearly symptomatic, looks like a GIST, they still always want us to do a biopsy. I don't know why. They want us to show that it's a GIST, and for some reason it changes their operative technique or something. I'm not sure I understand.
Yeah.
But to me, this, just because it's symptomatic, they have to take out the whole thing. I don't see how this histology will change.
Shall we ask the audience? Shall we ask the audience how many people would FNA this lesion and how many would just send it to the surgeon?
Even if it was a
Hands up for
lipoma,
FNA.
it's a bleeding lipoma.
We're getting a handful of people would do an FNA. How many people would definitely not do an FNA in this case? By far the majority are against doing an FNA in this case.
Yeah, and anyway, FNA for GIST are best with a 19-gauge needle, but a 19-gauge needle for a lesion that's less than 2 centimeters is usually very difficult because the lesion usually moves with the needle, so it's very difficult to have movements of the needle in a lesion that's usually quite, if we do some elasto, which are quite stiff, and they are usually very blue, as you see.
Yeah.
It's really a clear blue pattern, which means a very stiff lesion. So not very easy to puncture,
and
actually.
if there's an ulceration, you can always go into the ulceration and biopsy straight into the... What I do sometimes is I'll if there is an ulceration, you can take a biopsy forceps, and by EUS, you can see the biopsy forceps going into the tumor, and just open it up and take a picture, take a piece.
Yeah, that's sometimes we do that. We de-roof.
So Pierre, your decision, please.
So this looks like a GIST on the EUS aspect. It's connected to the muscular propria. It may be resected by ESD with a tunneling technique, but this is still not validated technique. So I think it's a good indication for surgical laparoscopic excision without any FNA.
And it's on the anterior wall, or
perfect. We agree.
Okay.
Very good.
We agree with you. Thank you.
Okay,
Thank
perfect.
you so much.
Thank you very much.